Now we ended an astonishing session. Now we are going to start our next session, which is on proctology. Our respected chairpersons are Dr. Ameet Kumar, Dr. Saumitra Rawat, and Dr. Predeep Nemani. Now I will hand over the session over to our respected chairpersons. Thank you.
Good morning, everyone. Can I invite Dr. Bhushan Agarwal, my very dear colleague, a top colorectal surgeon, editor-in-chief of Indian Journal of Colorectal Surgery. He's going to talk about a very exciting topic, surgery for obstructed defecation syndrome, ODS. And it's a very complicated topic. I think he will shed a lot of knowledge. He does quite a lot of surgery about ODS. And this is the surgery where surgeons are always at a fix what to do. Conservative surgery, what kind of surgery. I think it's very important we do the right surgery to treat the patient.
Yeah,
Welcome.
Good morning. Thank you very much, Dr. Rawat. I think it's a blessing to have you as one of the chairpersons. We've been together at Maulana Azad and now at Gangaram, you being our chief and spearheading all the GI surgeries. And thank you for your very kind introduction, and thank you the organizing team for giving me this opportunity in presence of many of teachers. And speaking after two stalwarts reminded me of a debate I was participating in with Editor-in-Chief of Surgical Endoscopy, Bruce McFadden. The topic of debate was evidence-based surgery, can innovations wait? So I stand still on the side that innovations cannot be stifled for evidence to come out in surgery. Surgeons have to think out of the box and they have to innovate. I bring greetings from my institute, Gangaram Hospital at Delhi. And ODS, as Saumitra said, it's a very complex problem to understand. It's not complex to treat. I think it's what we know is the tip of the iceberg. So if we understand it properly, we may benefit our patients, but most of our patients, my patients, remain unsatisfied despite best of evidence, which is not there. So thank you very much. I have no conflicts of interest. I'll be using the acronym ODS for obstructed defecation syndrome in my presentation, and presentation will be based upon American College of Surgeons and American Society of Colorectal Surgeons guidelines and some of our own publications. We have published, and in my presentation and practice, we use a simplified constipation score. We call it constipation and bowel activity score. Simple, like a scale based 0 to 4 marks you have to give. If the score is more than 15, then we investigate further for ODS. Otherwise, we refer it back to our gastrophysician colleagues. So before we think of surgery, even if we have made up our mind that this person needs surgery, we must exclude everything else which can cause constipation, because it's a benign condition. It's not a life-threatening condition. It might be impeding the quality of life. So before we put knife to the patient, we exclude everything. When and what to do is more important, not how to do. And most important thing, although we know Rome 3 criteria, we should rule out constipation, predominant irritable bowel syndrome, but slow transit constipation, although an excluding feature from ODS, it's a separate entity. Many of these patients will have overlap of some degree of transit problem as well as ODS. So I'll be including transit problem with ODS in my presentation. As I said, which and why is more important, not how to do it. Unfortunately, right from our residency training days, we focus on how to do a surgery. I think it is important to decide what to do and when not to do. So when we are planning surgery, we revise the history of the patient. We exhaust every possible manner which we can advise our patient to increase the bowel activity by daily. That's diet review. Then the patient should remain active, increase exercise. We train the bowel habits of the patient and inculcate habits which are culturally acceptable, like yoga. And I tell my patients that, and we know that nitric oxide donor diets improve bowel activity. So, and it has been seen that cooking in non-stick vessels because of Teflon and aluminum destroys the NO synthetase enzyme. So we should promote patients not to eat food cooked in these vessels. We exclude everything, and we must remember 2 or 3 basic things. We have to exclude irritable bowel syndrome. In irritable bowel syndrome, patient will always have some abdominal discomfort or pain relieved by passage of movement of bowel. In ODS, there is no abdominal discomfort. Patient is never complaining. Similarly, in transit problems, patient on getting up early in the morning or even taking light breakfast or heavy meal does not feel any urge to move his or her bowel, then it is a transit problem, it is not ODS. Similarly, many of these patients we assume to be ODS because they are doing digital evacuation, but there is no bleeding in ODS patients unless there is concomitant hemorrhoidal disease, no fissure, sorry. So if there is blood on digitized finger, then we should exclude some other sinister pathologies which might have been missed despite our exhaustive medical evaluation. Similarly, before we proceed for rectal manometry for pelvic floor dyssynergia, a simple digital rectal examination by asking patient to push the stools or hold stools. So when the patient is pushing stool, he should relax your examining finger. If he is holding stools, he should squeeze your examining finger. So if he is not doing it properly, if it is reverse, paradoxical, then it is pelvic floor dyssynergia. No need of proceeding with these patients without manometry or proper evaluation. Coming to ODS, the hallmark after clinical presentation, scoring systems, and basic evaluation remains imaging, dynamic defecography, usually done nowadays with MR, but at Gangaram we do both. We were the first ones to start defecography in India. So what we can find on defecography? We can find a rectocele or an intussusception, which is rectorectal or rectoanal. We can simply find nothing but mucosal prolapse, which we call as rectal mucosal prolapse or internal rectal prolapse. So rectocele is a very benign finding in normal population, especially in females. 80% of females after 40 years of age will have a rectocele. So it is very important that only non-emptying rectocele. Size is not important. Many articles say more than 4 centimeters, 3, 5, that way. What we have to see in dynamic imaging is the rectocele emptying, or the patient has to do vaginal splinting and put the finger to empty the rectocele. If it is not emptying, it is pathological. Now coming to evidence, as we should practice evidence-based surgery, but unfortunately in ODS, evidence level is not very strong. So as I said, transit and ODS do overlap, so we must consider if the patient has exhausted all means of medical management and he has ODS with slow transit, we should consider these desperate patients. Evidence says that total abdominal colectomy with ileorectal anastomosis might help these patients, but I can't recall more than 2 or 3 patients in my practice of since 2006 I've been dealing with ODS who have needed or have done this. Then there is literature saying subtotal colectomy with ceco-anal anastomosis preserves the ileocecal junction, hence reduces the chances of diarrhea or symptoms like those of LARS. Now, how to deal with patients who satisfy all criteria of ODS but also have refractory slow transit? The evidence says deal with ODS first, because transit problems requiring surgical intervention, the surgery is quite morbid, so it is better to proceed with ODS management first before proceeding to colectomies. Coming to rectoceles, as I said, non-emptying rectoceles, they need not be repaired unless they are the only finding in defecography. If there is intussusception and rectocele, forget rectocele. So if there is nothing but rectocele and it is non-emptying, should be repaired transvaginally, as the gynae colleagues do, because it is better, it does not disturb the anal mucosa, hence less chances of infection and fistulization. We surgeons can repair it transrectally, the advantage being less urinary or sexual or defecatory dysfunction, and you can address other anorectal findings if the patient has hemorrhoid or something, symptomatic hemorrhoids. Transperineal is what we prefer. It is good because you can do lavetroplasty in the same sitting. This has strong recommendation, but quality of evidence is also good. Rest of the procedures I will be talking about, quality of evidence is not so good. Patient having both rectocele, non-emptying and intersusception. So the only thing that can be offered in one go is a transanal surgery, stapled transanal resector anastomosis. Literature is full of complications because of STAR. There is a lot of antagonism to it, but in selective patients, this can be offered. Recommendations are weak and quality of evidence is not very weak, not very strong. Only rectal intersusception. So in my practice, also in literature, these are the patients who benefit most from surgical intervention. If the patient has only intersusception, no transit problem, no dyssynergia, no non-emptying rectocele. So you can, literature says STAR. People who prefer STAR like me, they go for STAR. Many colleagues go for rectopexies. So recommendation level, weak recommendation, low quality of evidence. Nowadays we know, so STAR I'm not talking about because I am biased towards STAR. I'm talking about rectopexies. What does the literature say? They say none of the procedures, we had more than 100 procedures to start with, none of the procedures improved the quality of life. De novo constipation, we all agree that in more than 30% of 1/3 of the patients is a finding because of the dissection on the sacral bed. The sexual and urinary disturbances are inevitable outcome of these procedures. Numbers may be low in full-blown condition, but suboptimal, subclinical outcomes in almost all patients. So limited dissection over the sacrum made the ventral suture rectopexy or ventral mesh rectopexy more commonly practiced, and it is gaining in popularity now. Laparoscopic, open or robotic, I say it should never be debated in an academic meeting because laparoscopy and robotics are tool. At Gangaram, we do only laparoscopy and robotic, but still, we have to reproduce the wisdom of conventional surgery. Advantages of laparoscopic surgery, whether it is cholecystectomy, hernia or rectopexy, are because of the decreased parietal and visceral morbidity. There is nothing to glamorize laparoscopic or robotic surgery. So debate is that ventral rectopexy, whether suture or using mesh, is a better procedure compared to the older rectopexies. But what does the literature say? Do the rectopexies help? They say more than 50% of patients do not improve their outcome, and the studies have very short follow-up. Ventral rectopexy, even shorter follow-up, although results are published as better. I say, why to violate the virginity of peritoneal cavity for something you do transanally? Why to destroy the slide of the rectum on the sacrum? Because defecation requires that. If you do rectopexy, that is fixed. And why to go from lateral pelvic wall to medially hit the rectum? Why not go from the lumen centrifugally to complete your procedure? So these are my arguments in favor of STAR. And David Jain, who is a good friend, wrote an editorial in BJS saying STAR does not need any level 1 evidence or any RCT for level 1 evidence because there is enough data. In selected patient, it has very good outcomes. And these were the criteria. I am rushing because time given was very less. So 9 seconds left. So STAR is better than biofeedback in selected patients. So my final slide is, I say decide. Pelvis is a 3-compartment, why fix all the compartments? If it is isolated posterior compartment, do STAR, as it is in male patients of ODS. In female patients of ODS, middle compartment is always involved with posterior compartment, so do ventral rectopexy, whether you do suture or mesh, laparoscopic, robotic or open, that is immaterial, results are equally good. So decide which compartment of pelvis is involved. And this is, time is up. So this is a new procedure Dr. Longo devised, and I was the first one to be trained by him, in which you address posterior and middle compartment without putting any intraperitoneal mesh or putting mesh in contact with the viscera. So what he does is a V-shaped proline sling. The tip of the V is sutured to the uterosacrals in females. The two limbs are brought behind the uterus and in front of the uterosacrals. And from the extraperitoneal tunnel that we do TEP repair of inguinal hernias, he brings them out and tacks them to the anterior superior iliac spine. So if it is anterior compartment involvement leading to stress urinary incontinence or cystocele or erythrocele or prolapse of anterior wall of the vagina, then he puts the mesh anteriorly on the cervix and pulls it out extraperitoneally. And what are the other things? Mixture, I have no experience of appendicostomy or cecostomy. Literature mentions in highly motivated patients who have been refractory to all surgical interventions. This has weak recommendation, low quality of evidence. Sacral nerve modulation, I have witnessed a lot, Dr. Wexner doing it, Dr. Longo and Scherer doing it. I am very impressed, no personal experience. It has got good results as per their publications and a moderately good quality of evidence, but still recommendations are weak because, as I said, surgery innovation necessarily need not be tested by RCT. What needs to be tested is it reproducible in its outcome across geographies, as Dr. Kate said, across surgical hierarchies from junior to senior. That's why Lakenstein repair of hernia remains gold standard, because TP cannot be reproduced. So in other studies, they say you can do a completion proctectomy in patients who have done subtotal and they have not benefited, and do a pouch. No personal experience. And this is my favorite statement, because we at Gangaram are usually laparoscopic 99.99% and 0.1% robotic. So the tools don't make you a good surgeon in terms of clinical outcomes. We remain fool even if a good tool is given our hand, if we do not replicate the wisdom of open surgery era. So a surgeon should have many tricks up its sleeve. Thank you very much. I wrote this editorial. I talked about that debate with Bruce McFadden. They invited me to write the editorial, and still believe that we as surgeons have to innovate, understanding the molecular basis of the disease physiology, respecting traditional wisdom. We have published RCTs about turmeric, music, yoga, etc. And then we have to understand each patient needs customization of our approach. Surgeons of futures will be promoting ERAS protocols. They'll be working like team. Together everyone achieves more. The evidence which matters to the patient is more important, not just the publication and filling up print sheets. So patient-oriented evidence matters. We must pursue, and we should adopt the tools to enhance the return of A, B, C, D, E, F within 2 or 3 days of surgery. A for activity, B for bath, C for commitments, D for diet, including spices. We published RCT about spices in Indian diet, helping the post-operative recovery in surgical endoscopy. So thank you very much. Thank you.
Any questions? Anybody wants to ask any questions?
There is a video of Popstar. Anybody interested can take it from here. 6 minutes video of pelvic organ prolapse surgery.
Any comment from senior faculty before we give our comments? So I think you presented it so well.
No, thank you very much. And I forgot to say, Dr. Rawat has blessed us with the first of its kind 1-year diploma program after surgical training completion at Gangaram, and he will be starting it.
I think very well presented. I think selection of patient is very important, and like you rightly said, that if it is a rectocele with intussusception, star is a procedure. In female, you need to think about ventral rectopexy, and if somebody has got a redundant sigmoid colon, then resection.
I kept that out because that doesn't come in ODS.
It's complicated, but for them, I just want to say that,
constipation, predominant rectal prolapse pathologies, resection rectopexy.
Resection rectopexy.
And incontinence or non-constipating rectal prolapses, there are many options. Ventral rectopexy is gaining momentum.
Absolutely. But the key part here is, if you are planning a surgery, get a defecography done and manometry, because you want to plan your surgery in a good way. What kind of surgery you do, that will depend the outcome of your surgery.
Thank you very much.
Thank you. Thank you, everybody.